Welcome, future histotechnologists, to Week 10 of HTL 308. Today, we embark on a critical journey into the realm of acute leukemias and the nuanced art of blast recognition. Throughout this course, we meticulously explored the intricate world of blood cells, starting with red blood cells and their vital roles in oxygen transport. We then shifted our focus to white blood cells, understanding their dynamic responses to infection and inflammation, acting as the body's vigilant defenders. Now, we confront a more challenging aspect. What happens when the very systems responsible for producing and maturing these essential cells go awry? This week, we're moving beyond the body's normal responses to external threats and delving into the internal failures of the hematopoietic system itself. This shift requires a keen eye and a deep understanding of cellular morphology, as we learn to distinguish between a healthy, reactive response and a dangerous, uncontrolled proliferation. Our goal is to equip you with the knowledge to identify these critical cellular anomalies, which are often the first indicators of severe underlying pathologies. This foundational understanding is paramount for accurate diagnosis and timely patient intervention in the clinical laboratory. We've covered a lot of ground in this course, moving from the basics of red blood cells to the complexities of white blood cell responses. Remember our initial deep dives into RBCs, understanding their life cycles and how they carry oxygen? That foundational knowledge was crucial. Then, we transitioned to WBCs, exploring their diverse roles in immunity and how they react to various stimuli like infections and inflammation. We learned to identify the morphological changes associated with these reactive states, where the immune system is actively engaged in defending the host. Now, we're building on that understanding, moving into the realm of disorders where the normal regulatory mechanisms of blood cell production are compromised. This progression is logical. You can't truly grasp pathology without first mastering physiology. This week, we're taking a significant step into understanding what happens when these systems fail. This sets the stage for our discussion on acute leukemias, where the very production line of blood cells goes awry. Our journey so far is largely centered on understanding how the body's white blood cells respond to various stimuli, such as infections or inflammatory processes. We've learned to identify the morphological changes associated with these reactive states, where the immune system is actively engaged in defending the host. However, this week marks a pivotal transition in our perspective. We are shifting our focus from observing the body's responses to external challenges to understanding what occurs when the system itself malfunctions. This is a fundamental conceptual leap, moving from a scenario where cells are behaving in a controlled, albeit heightened manner, to one where the control mechanisms have been lost. This loss of control manifests as abnormal cell production and maturation, leading to conditions like acute leukemias. It's no longer about identifying a robust immune reaction. It's about recognizing the subtle yet profound indicators that the hematopoietic machinery is failing. This distinction is crucial for accurate diagnosis, as misinterpreting a malignant process as a reactive one can have severe consequences for patient care. Therefore, developing the ability to discern between these two states is a cornerstone of your advanced training. This leads us directly to a critical big idea for this week. One of the most profound insights you will gain this week is that the presence of abnormal white blood cells in a peripheral blood smear does not automatically equate to a reactive process. While many morphological variations we've studied previously were indeed indicative of the body's appropriate immune responses, a critical subset of abnormal cells represents something far more sinister, a loss of inherent cellular control. This distinction is paramount in hematology. In reactive conditions, the body produces an increased number of white blood cells, often with some atypical features. But these cells are still part of a coordinated effort to combat an infection or inflammation. Their morphology, though varied, typically shows a spectrum of maturation, indicating an orderly, albeit accelerated, production process. However, in malignant conditions like leukemia, the abnormal cells are not part of a beneficial response. Instead, they represent a clonal expansion of immature cells that have lost their ability to differentiate and mature properly. This uncontrolled proliferation disrupts normal hematopoiesis, leading to a host of clinical problems. Therefore, recognizing that an abnormal white blood cell might signify a fundamental breakdown in cellular regulation, rather than just an exaggerated immune response, is a cornerstone of accurate diagnosis and patient management. This understanding will guide your interpretation of peripheral blood smears and bone marrow aspirates, allowing you to differentiate between benign and life-threatening conditions. This big idea directly informs our learning focus for the week. This week, our learning objectives are sharply focused on developing your ability to precisely identify and interpret critical cellular features. Firstly, you will master the recognition of blasts, which are immature precursor cells normally confined to the bone marrow. Their presence in the peripheral blood is a significant red flag, indicating a potential disruption in normal hematopoiesis. Secondly, we will delve into the crucial skill of distinguishing between reactive and malignant patterns of leukocyte abnormalities. This involves a meticulous examination of cellular morphology, including nuclear to cytoplasmic ratio, chromatin pattern, present or absence of nucleoli, and cytoplasmic characteristics. Understanding these subtle differences is vital, as misinterpretation can lead to delayed or incorrect diagnoses. Finally, you will learn to connect these morphological observations directly to the underlying marrow dysfunction. The peripheral blood often serves as a window into the bone marrow, and changes observed in circulating cells can provide invaluable clues about the processes occurring within the hematopoietic factory. By the end of this module, you should be able to articulate how specific cellular features correlate with the physiological state of the bone marrow, whether it's a controlled response or an uncontrolled proliferation. This integrated approach to morphology and pathophysiology is essential for any upper-level histotechnologist. This focus on early recognition is critical, and we'll explore why next. The ability to accurately recognize blasts and differentiate between reactive and malignant patterns isn't just an academic exercise. It has profound clinical implications. Early and accurate recognition of leukemia is paramount for patient survival and effective treatment. Leukemias are aggressive cancers of the blood and bone marrow, characterized by the rapid proliferation of abnormal, immature blood cells. If left undiagnosed or misdiagnosed, these conditions can quickly progress, leading to severe complications and often fatal outcomes. The peripheral blood smear, which you will be expertly analyzing, serves as a critical window into the marrow. It provides the first and often most accessible evidence of what is happening within the hematopoietic system. Abnormal cells circulating in the blood can signal a profound disruption in bone marrow function, prompting further diagnostic investigations such as bone marrow biopsies. Your role as a histotechnologist in identifying these early indicators is indispensable. A timely and precise report from the laboratory can trigger immediate clinical intervention, potentially saving a patient's life. Therefore, the skills you develop this week are directly linked to improving patient outcomes and are a testament to the critical importance of your profession in the healthcare ecosystem. Now, let's quickly review what a reactive pattern looks like. Before we delve deeper into malignant patterns, let's briefly review the characteristics of a reactive pattern in white blood cells, which we have previously discussed. A reactive process is the body's normal physiological response to various stimuli, such as infections, inflammation, or stress. When examining a peripheral blood smear in a reactive state, you will typically observe several key features. Firstly, there is often significant variation in cell size and morphology within a particular cell line. For instance, in a reactive lymphocytosis, you might see a spectrum of lymphocyte forms, from small resting lymphocytes to larger, more activated forms with abundant cytoplasm. Secondly, you will usually find cells exhibiting mixed maturity, meaning there is a presence of both mature and immature forms, but always in an orderly progression. This indicates that the bone marrow is responding appropriately by increasing production and releasing cells at different stages of development. Finally, there is clear evidence of response, such as toxic granulation, dough bodies, or cytoplasmic vacuolation in neutrophils, all indicative of heightened cellular activity to combat an underlying condition. These features collectively paint a picture of a well-regulated, albeit stimulated, hematopoietic system working to maintain homeostasis. Understanding this normal reactive spectrum is essential for accurately identifying deviations that suggest a malignant process. Now, let's contrast this with a malignant pattern. In stark contrast to the reactive pattern we just reviewed, A malignant pattern in white blood cells signifies a profound loss of cellular control and an underlying neoplastic process. When you encounter a malignant pattern, several distinctive features will emerge. Foremost among these is uniformity in the appearance of the abnormal cells. Unlike the varied morphology seen in reactive conditions, malignant cells, particularly blasts, often look remarkably similar to one another. This uniformity reflects their clonal origin. They all arise from a single aberrant precursor cell. Secondly, a hallmark of malignancy is pronounced immaturity. The cells fail to differentiate and mature properly, remaining in an immature blast stage. This means you will see a predominance of blasts with features such as a high nuclear to cytoplasmic ratio, fine chromatin, and prominent nucleoli, indicating active proliferation rather than maturation. Finally, there is a distinct loss of normal progression through the maturation stages. The orderly sequence of cell development, from blasts to mature forms, is disrupted or completely absent. Instead, the bone marrow is often overrun by these immature cells, crowding out normal hematopoiesis. This combination of uniformity, immaturity, and disrupted maturation is a critical indicator of a malignant process, necessitating urgent further investigation and diagnosis. This brings us to a key question you must always ask. As you analyze peripheral blood smears and bone marrow aspirates, the central question that should always guide your critical thinking is, does this look like a response or a system failure? This seemingly simple question encapsulates the fundamental diagnostic challenge in distinguishing between benign reactive conditions and malignant leukemias. A response implies a controlled, albeit sometimes exaggerated, physiological reaction to an external stimulus, where the body's regulatory mechanisms are still intact. In such cases, you would expect to see a diverse population of cells, some mature, some immature, but all contributing to a coordinated defense. Conversely, a system failure points to an internal breakdown in the hematopoietic process itself, where cellular proliferation and maturation are no longer under proper control. This often manifests as a monotonous population of immature cells, such as blasts, that are not effectively contributing to normal blood cell function. Your expertise lies in meticulously examining the morphological clues, the nuclear to cytoplasmic ratio, chromatin patterns, nucleoli, and cytoplasmic characteristics, to determine which scenario is more likely. This critical evaluation is not just about identifying abnormal cells. It's about interpreting the underlying biological narrative they convey. By consistently asking this question, you will sharpen your diagnostic acumen and contribute significantly to accurate patient care, guiding clinicians toward appropriate interventions. Remember, the cells are always telling us something. In the intricate world of hematology, cells are far from random entities. They're profound storytellers, and their morphology serves as compelling evidence of the underlying biological processes. Every feature you observe under the microscope, the size and shape of the nucleus, the texture of the chromatin, the presence or absence of nucleoli, and the characteristics of the cytoplasm, provides a crucial piece of information. These cellular attributes are not arbitrary. They directly reflect the cell stage of maturation, its functional state, and critically, whether it's part of a normal, reactive process or an uncontrolled, malignant proliferation. For instance, a high nuclear to cytoplasmic ratio with fine, open chromatin and prominent nucleoli strongly suggests immaturity and active proliferation, often seen in blasts. Conversely, a segmented nucleus with clumped chromatin and abundant cytoplasm points toward a mature, differentiated cell. Your role as a histotechnologist is akin to that of a detective, meticulously gathering these morphological clues and piecing them together to interpret the cellular narrative. This narrative, in turn, reveals the underlying biology, guiding clinicians toward an accurate diagnosis and appropriate treatment strategy. Trust in the evidence that the cells present. They rarely lie about the state of the hematopoietic system. Next, we'll define exactly what a blast is. At the heart of our discussion this week is the blast cell, a term you will encounter frequently, and one that carries significant diagnostic weight. A blast is, by definition, an immature precursor cell, the earliest recognizable form of a blood cell in its developmental lineage. Under normal physiological conditions, blasts are primarily found within the protective environment of the bone marrow, where they undergo a carefully regulated process of proliferation and differentiation into mature blood cells. Their presence in the peripheral blood is an abnormal finding and a critical indicator of potential pathology. These cells are characterized by their undifferentiated state, meaning they have not yet committed to a specific mature cell line or have failed to progress through the normal maturation stages. Recognizing blasts accurately is fundamental because their uncontrolled proliferation and accumulation are the defining features of acute leukemias. Therefore, understanding their characteristic morphology and the implications of their presence outside the bone marrow is a cornerstone of diagnosing these aggressive hematological malignancies. This knowledge forms the basis for distinguishing between benign and life-threatening conditions, making blast identification a paramount skill for histotechnologists. The presence of blasts in the peripheral blood is not merely an interesting morphological observation. It is a profoundly significant clinical finding that demands immediate attention. As we just discussed, blasts are immature precursor cells normally confined to the bone marrow. Their appearance outside the bone marrow strongly suggests a fundamental disruption in normal hematopoiesis, indicating either abnormal production or premature release of these immature cells. Normally, the bone marrow acts as a tightly regulated factory, releasing only mature, functional blood cells into circulation. When blasts escape this control and appear in the peripheral blood, it signals that the regulatory mechanisms governing cell development and release have been compromised. This can be due to an uncontrolled proliferation of these immature cells within the marrow, leading to their spillover into the bloodstream, or a failure of the marrow to properly mature its cells. In either scenario, the presence of blasts is a critical indicator of potential acute leukemia, a condition characterized by the rapid, uncontrolled growth of these undifferentiated cells. Therefore, identifying blasts is a crucial first step in diagnosing these aggressive diseases, prompting further investigations and enabling timely therapeutic interventions that can significantly impact patient outcomes. Now, let's look at the specific features that help us identify these critical cells. While blasts can exhibit some variability depending on their lineage, there are several core morphological features that are consistently observed and are crucial for their identification. These features collectively form a diagnostic triad that distinguishes blasts from more mature cells. Firstly, blasts typically exhibit a high nuclear to cytoplasmic (NC) ratio. This means the nucleus occupies a disproportionately large volume of the cell, with only a scant rim of cytoplasm surrounding it. This high NC ratio is a hallmark of immaturity and rapid proliferation. Secondly, the nucleus of a blast contains fine, open chromatin. Unlike the clumped, condensed chromatin seen in mature cells, the chromatin in blasts appears delicate and evenly dispersed, reflecting active DNA replication and transcription. This open chromatin pattern is a key indicator of an immature cell. Thirdly, blasts often possess prominent nucleoli. These are distinct, usually round or oval structures within the nucleus that are sites of ribosome synthesis, indicating high metabolic activity and rapid cell growth. Finally, blasts typically have scant cytoplasm, which is often basophilic blue, due to a high concentration of RNA, further emphasizing their immature and rapidly dividing nature. While not always present, the combination of a high NC ratio, fine chromatin, and prominent nucleoli are the most reliable morphological indicators for identifying blasts in a peripheral blood smear or bone marrow aspirate. Mastering the recognition of these features is essential for accurate diagnosis in hematology. Let's break down each of these features, starting with the NC ratio. Let's delve deeper into one of the most critical morphological indicators of a blast cell, the nuclear to cytoplasmic NC ratio. As we just noted, this ratio describes the proportion of the cell occupied by the nucleus relative to its cytoplasm. In blast cells, this ratio is characteristically high, meaning the nucleus is disproportionately large, often taking up 80% or more of the cell's total volume, with only a very narrow rim of cytoplasm visible. This high NC ratio is a direct reflection of the cell's immaturity. As cells mature and differentiate, they typically accumulate more cytoplasm, which is necessary for their specialized functions. Immature cells, like blasts, are primarily focused on rapid proliferation and DNA replication, hence the large nucleus and minimal cytoplasm. Think of it as a cell that is still in its early developmental stages, prioritizing nuclear machinery over cytoplasmic development. The presence of consistently high NC ratio across a population of cells in the peripheral blood is a strong indicator of an abnormal, immature cell population and should immediately raise suspicion for an acute leukemia. This feature, therefore, serves as a fundamental morphological clue in blast identification. Next, we'll examine the chromatin pattern. Another crucial feature for identifying blasts, following our discussion on the NC ratio, is their distinctive chromatin pattern. Chromatin refers to the complex of DNA and proteins that forms chromosomes within the nucleus. In mature cells, chromatin is typically condensed and clumped, appearing as dark, dense areas within the nucleus. However, in blast cells, the chromatin is characteristically fine and open, often described as delicate or lacy. This less condensed appearance is a direct indicator of immature DNA organization and high metabolic activity. When a cell is actively dividing and replicating its DNA, the chromatin needs to be in a more relaxed, open state to allow for transcription and replication. The fine, open chromatin pattern in blasts signifies that these cells are rapidly proliferating and have not yet undergone the condensation associated with differentiation and maturation. Therefore, observing a uniform population of cells with fine, open chromatin, especially in conjunction with a high NC ratio, is a powerful morphological clue that you're likely looking at blasts, which are indicative of an acute leukemic process. Now, let's consider the nucleoli. Let's move on to nucleoli, another critical feature in blast identification. Nucleoli are typically visible and prominent in blasts, which is a strong indicator of active transcription. This prominence tells us the cell is highly metabolically active, rapidly synthesizing proteins and RNA for quick growth and division. In mature, quiescent cells, nucleoli are often absent or very indistinct, so their clear presence in an immature cell is a significant clue. Think of it as the cell's engine running at full throttle, preparing for rapid proliferation. This feature, combined with fine, open chromatin we just discussed, paints a clear picture of an immature, rapidly dividing cell. We're building a comprehensive profile here, piece by piece. Next, we'll examine the cytoplasm, which also offers important insights into a cell's maturity. Now, let's consider the cytoplasm, which provides a final piece of our morphological triad for blasts. In blasts, the cytoplasm is typically scant, meaning there's very little of it compared to the large nucleus. This contributes to that high nuclear to cytoplasmic ratio we talked about earlier. Furthermore, the scant cytoplasm is often basophilic, staining blue or deep blue with right Giemsa stain. This basophilia is due to a high concentration of ribosomal RNA, reflecting the cell's active protein synthesis. Importantly, the cytoplasm of blasts may lack mature granules, further emphasizing their immature state. While some myeloblasts can have a few nonspecific granules, the absence of specific granules is key. This combination of scant basophilic cytoplasm, often devoid of mature granules, helps us differentiate blasts from more mature or reactive cell types. So, we've covered the nucleus, chromatin, nucleoli, and now the cytoplasm. These are the individual features. But what about the population as a whole? Let's look at that next. Beyond the individual cellular features, an important characteristic to observe when identifying blasts is their uniformity. In a malignant process like acute leukemia, the abnormal cells, particularly the blasts, often look remarkably similar to one another. This uniformity is a key indicator that these cells represent a clonal population. A clonal population arises from a single aberrant progenitor cell that has undergone a malignant transformation and then proliferates uncontrollably. Because all these cells originate from the same mutated ancestor, they tend to share very similar morphological characteristics. This contrasts sharply with reactive conditions, where you would typically see a more heterogeneous population of cells, even within the same lineage. The monotonous appearance of blasts, with consistent features such as NC ratio, chromatin pattern, and nucleoli, provides strong evidence of a clonal expansion. This uniformity is a significant diagnostic clue for acute leukemia, helping us differentiate a true leukemic process from other conditions that might present with immature cells. To truly appreciate these features, it's helpful to contrast them with what we see in a mature, healthy cell. To truly appreciate the defining features of a blast cell, it's essential to contrast them with the morphology of a mature cell. Consider a mature neutrophil, for example. In a mature cell, the nucleus is typically segmented or lobulated, often appearing as multiple distinct lobes connected by thin filaments. The chromatin within the nucleus is clumped and condensed, appearing as dark, dense aggregates rather than the fine, open patterns seen in blasts. This condensed chromatin indicates a cell that is no longer actively dividing, but is instead focused on its specialized functions. Furthermore, mature cells possess abundant cytoplasm, which is often filled with specific granules that are crucial for their function. The nuclear to cytoplasmic ratio is low, as the cytoplasm occupies a much larger proportion of the cell. This distinct morphology of mature cells, segmented nucleus, clumped chromatin, and abundant, often granulated cytoplasm, stands in stark opposition to the features of blasts. Understanding this contrast is fundamental for accurately identifying immature cells and distinguishing them from their fully differentiated counterparts. This is a critical skill in diagnosing hematological disorders, and it helps us avoid a common pitfall: confusing blasts with reactive lymphocytes. One of the most common diagnostic challenges in hematology is distinguishing between a reactive lymphocyte and a blast cell, as both can appear atypical. However, there are several key morphological distinctions that allow for accurate differentiation. A reactive lymphocyte, often seen in viral infections, typically exhibits abundant cytoplasm that can be pale blue to deeply basophilic and may show peripheral or radial basophilia. The cell often has an irregular shape, with cytoplasm that can be indented by surrounding red blood cells. The nucleus, while sometimes irregular, usually has coarse-defined chromatin that is more condensed than a blast, and nucleoli may or may not be present. Crucially, reactive lymphocytes show variable appearance within the population, reflecting a diverse immune response. This variability is a hallmark of a reactive process. In contrast, a blast cell, as we've discussed, has a high nuclear to cytoplasmic ratio, scant cytoplasm, and a more uniform appearance within the blast population, indicative of a clonal process. Mastering these distinctions is vital for avoiding misdiagnosis, and we'll delve deeper into the specific features of blast cells next. Now, let's turn our attention to the blast cell itself, the critical indicator of acute leukemia. Unlike the varied appearance of a reactive lymphocyte, a blast cell presents with a distinct set of features that scream immaturity and uncontrolled proliferation. You'll immediately notice a high nuclear to cytoplasmic, or NC, ratio. The nucleus dominates the cell, leaving only a scant rim of cytoplasm. This is a hallmark of cells focused on rapid division rather than differentiation. The chromatin within that large nucleus will appear fine and open, often described as delicate or lacy, which reflects active DNA replication and transcription. This open chromatin is a key differentiator from a clumped chromatin of mature cells. Furthermore, blasts often exhibit a uniform appearance across the population, a strong clue that you're looking at a clonal expansion rather than a diverse immune response. This uniformity, coupled with a high NC ratio and fine chromatin, paint a clear picture of an immature, rapidly dividing cell. Understanding these core features is absolutely essential for accurate blast identification. We'll now summarize these critical distinctions between reactive and blast cells. To truly solidify our understanding, let's distill the key differences between reactive processes and blast cells into two overarching concepts. A reactive process is fundamentally a physiological response to a stimulus, characterized by significant cellular variation. You'll see a diverse population of cells, even within a single lineage, reflecting a coordinated immune effort. This variation includes different stages of maturation and a range of morphological features. In stark contrast, a blast cell embodies immaturity and uniformity. These cells are arrested at an early developmental stage, failing to mature properly, and they often look remarkably similar to one another. This uniformity is a critical indicator of a clonal population, suggesting an uncontrolled proliferation rather than a beneficial response. So, when you're evaluating an atypical cell population, always ask yourself, does this look like a diverse, coordinated response or monotonous, immature, and uncontrolled proliferation? This distinction is paramount for accurate diagnosis. Now, Let's consider a practical visual strategy to help us make these crucial differentiations. When you're faced with the challenge of distinguishing between reactive cells and blasts, a highly effective visual strategy is to systematically compare and contrast their key morphological features. This isn't about a quick glance. It's about a deliberate, focused examination of specific cellular components. First, meticulously assess the chromatin pattern. Is it fine and open, suggesting immaturity, or is it clumped and condensed, indicative of a more mature cell? Next, evaluate the cytoplasm. Is it scant and basophilic, typical of blast, or is it more abundant, perhaps with specific granules or irregular shapes, as seen in reactive lymphocytes? Finally, consider the uniformity of the cell population. Do all the abnormal cells look strikingly similar, suggesting a clonal origin, or is there significant variation in their size, shape, and internal features, pointing toward a reactive process? By systematically comparing these features side by side, you can build a comprehensive picture that allows for accurate differentiation. This methodical approach, focusing on these critical morphological markers, will significantly enhance your ability to correctly identify blasts. This systematic approach is crucial because we cannot rely on vague impressions. As upper-level histotechnologist students, your diagnostic approach must transcend subjective observations like, "It looks weird." While an initial impression of abnormality is a valuable trigger, your analysis must be grounded in critical thinking and the application of specific morphological features. Relying solely on a vague sense of abnormality is insufficient and can lead to misdiagnosis. Instead, you must systematically apply the knowledge you've gained about cellular morphology. This means actively identifying and articulating the precise features that make a cell abnormal. For instance, instead of simply noting a cell is weird, you should be able to describe its high nuclear to cytoplasmic ratio, the fine and open nature of its chromatin, the presence and prominence of its nucleoli, and the scant, basophilic quality of its cytoplasm. These are the objective, quantifiable features that provide the evidence for identifying a blast. This rigorous, feature-based approach ensures consistency, accuracy, and defensibility in your diagnostic interpretations. This moves you from a novice observer to a skilled professional. Now, let's put this critical thinking into context by looking at acute leukemias. Now that we have a solid foundation in blast recognition, let's transition to an overview of acute leukemias. At their core, acute leukemias are a group of aggressive hematological malignancies characterized by the uncontrolled proliferation of immature cells, specifically blasts, in the bone marrow and peripheral blood. This uncontrolled growth is coupled with profound failure of maturation, meaning these blasts do not differentiate into functional mature blood cells. The consequence of this dual pathology is significant marrow dysfunction. The rapidly expanding population of blast crowds out the normal hematopoietic stem cells, leading to a severe reduction in the production of healthy red blood cells, white blood cells, and platelets. This disruption of normal hematopoiesis results in the clinical manifestations of anemia, infection, and bleeding that are characteristic of acute leukemia. Unlike chronic leukemias, which typically involve more mature cells and have a slower progression, acute leukemias have a rapid onset and require immediate, aggressive treatment. Understanding this fundamental pathophysiology is crucial for comprehending the clinical picture and diagnostic urgency. We'll now look at the two main types of acute leukemias. Now that we've established the aggressive nature of acute leukemias, let's break them down into their two primary categories: acute myeloid leukemia, or AML, and acute lymphoblastic leukemia, ALL. This distinction isn't just academic. It profoundly impacts how we approach diagnosis and treatment. AML stems from the myeloid lineage, meaning the malignant transformation happens in precursors that would normally become granulocytes, monocytes, red cells, or platelets. You'll often see AML in adults, and its incidence actually increases with age. On the other hand, all originates from the lymphoid lineage, involving precursors destined to become B or T lymphocytes. All is predominantly a disease of childhood, making it the most common pediatric leukemia, but it can certainly affect adults too. While both involve uncontrolled blast proliferation, their cellular origins dictate very different morphological, immunophenotypic, and genetic features. So, Differentiating between AML and ALL is a foundational step in acute leukemia diagnosis. Next, we'll look at the critical features these two types of leukemia share, despite their distinct origins. Despite their different cellular origins, AML and ALL share several critical features that define them as acute leukemias, and these are what we need to focus on for initial recognition. First and foremost, both are characterized by the presence of blasts in the blood and bone marrow. These immature, undifferentiated cells are the absolute hallmark of acute leukemia, signaling profound failure of normal maturation and uncontrolled proliferation. Secondly, both conditions lead to a significant suppression of normal hematopoietic cells. As these leukemic blasts rapidly expand within the bone marrow, they physically crowd out and inhibit the production of healthy red blood cells, mature white blood cells, and platelets. This crowding effect directly causes the pancytopenia or bicytopenia we often see, leading to symptoms like anemia, increased infection risk, and bleeding. Thirdly, both AML and ALL typically have a rapid onset. Patients often present with symptoms that develop quickly, sometimes over just days or weeks, reflecting the aggressive nature of these diseases. This rapid progression means we need prompt diagnosis and immediate treatment. Understanding these shared features helps us grasp the overall clinical urgency and the diagnostic approach for all acute leukemias, regardless of their specific lineage. This crowding out of normal cells has a devastating impact on the bone marrow, which we'll explore next. The presence of acute leukemia has a truly devastating impact on the bone marrow, which is, of course, the primary site of all blood cell production. The most significant consequence is that the rapidly proliferating blasts literally crowd out normal hematopoiesis. Think of the bone marrow as a bustling factory, responsible for producing all the different types of blood cells the body needs to function. In acute leukemia, this factory becomes completely overrun by a single defective product, the blasts, which multiply uncontrollably. This overwhelming presence of immature, non-functional cells physically displaces the healthy hematopoietic stem cells and progenitor cells. These are the cells responsible for generating mature red blood cells, white blood cells, and platelets. As a result, the production of these essential normal blood components is severely impaired. This crowding effect leads directly to the clinical manifestations we see: anemia due to lack of red blood cells, neutropenia due to lack of mature neutrophils leading to increased infection risk, and thrombocytopenia due to lack of platelets, which causes bleeding. So, the marrow impact of acute leukemia isn't just about the presence of abnormal cells. It's about the profound disruption of the entire blood-forming process, leading to systemic consequences for the patient. This disruption then manifests as very specific clues in the peripheral blood, which we'll discuss now. The peripheral blood smear often provides the initial and most critical clues for diagnosing acute leukemia, acting as a direct reflection of the underlying bone marrow pathology. When you examine a peripheral blood smear from a patient with acute leukemia, you'll typically observe a constellation of findings. First, anemia is almost universally present, indicated by a decreased red blood cell count and often a low hemoglobin level. This is a direct consequence of the blast crowding out normal erythropoiesis in the bone marrow. Second, thrombocytopenia, a reduction in platelet count, is also a very common finding, leading to an increased risk of bleeding and bruising. This results from the suppression of megakaryopoiesis. Third, the white blood cell count can be quite variable. It might be significantly elevated, decreased, or even within the normal range. However, regardless of the total WBC count, the most definitive and critical finding is the presence of blasts. Their appearance in peripheral blood, often in significant numbers, is a hallmark of acute leukemia and necessitates immediate further investigation. These combined peripheral blood findings, anemia, thrombocytopenia, and the presence of blasts, form a powerful diagnostic signature that alerts us to the urgent possibility of acute leukemia. Now, let's dive into the specifics of acute myeloid leukemia, or AML. Let's now focus specifically on acute myeloid leukemia. AML, one of the two major categories of acute leukemias. AML is actually a heterogeneous group of aggressive hematological malignancies that originate from the myeloid lineage. This means a malignant transformation occurs in the myeloid stem cells or progenitor cells, which are normally destined to develop into granulocytes like neutrophils, eosinophils, basophils, or monocytes, red blood cells, or megakaryocytes, which produce platelets. Consequently, the blasts we see in AML are specifically myeloblasts. While AML can occur at any age, it's often seen in adults, with the incidence increasing significantly with age. In fact, it's the most common acute leukemia in adults. The clinical presentation of AML is often characterized by symptoms directly related to bone marrow failure, such as fatigue due to anemia, infections due to neutropenia, and bleeding due to thrombocytopenia. Diagnosis relies on identifying at least 20% myeloblasts in the bone marrow or peripheral blood, along with specific morphological, cytochemical, immunophenotypic, and genetic features that help us classify the various subtypes of AML. Understanding that AML stems from the myeloid lineage is fundamental to interpreting its characteristic cellular morphology, which we'll explore next. Now, let's dive into the specific morphological features that characterize acute myeloid leukemia, or AML. We're talking about myeloblasts here, the immature myeloid precursors that define this disease. Myeloblasts typically present with moderate amount of cytoplasm, often basophilic, which can be a key differentiator from their lymphoid counterparts. What's particularly important is that these myeloblasts may contain granules, ranging from fine to somewhat coarse, providing an early clue to their myeloid lineage. But the real game changer, the definitive marker we actively seek, is the presence of our rods. These needle-like inclusions are almost exclusively found in myeloid cells and are a strong indicator of AML. While not every myeloblast will have them, their identification is a critical diagnostic finding. So, when you see blasts with moderate cytoplasm, potential granulation, and especially those telltale hour rods, your diagnostic radar should immediately ping for AML. This morphology helps us distinguish AML from other acute leukemias, guiding further testing and treatment. Remember, these subtle cytoplasmic and inclusion differences are what separate the myeloid from the lymphoid. This brings us to a closer look at these unique inclusions. Building on our discussion of AML morphology, let's focus specifically on our rods, because they are truly a myeloid signature. These are distinctive needle-like or rod-shaped inclusions found within the cytoplasm of myeloblasts and promyelocytes. They're essentially abnormal aggregations of primary granules, which are characteristic of myeloid cells. The presence of our rods is considered a strong clue for myeloid origin and is almost pathognomonic for AML. This means they are never found in lymphoblasts, making them an invaluable tool for differentiating AML from all. Even finding just one in a blast population is highly suggestive of AML. These structures can vary in size and number, sometimes appearing as single rods or, less commonly, in bundles, which we call faggot cells, particularly associated with acute promyelocytic leukemia. So, meticulously scanning for these distinctive inclusions is a critical step in your morphological analysis. Their identification provides definitive evidence for a myeloid leukemic process. Next, we'll compare the cytoplasmic characteristics of AML blasts to further refine our diagnostic eye. Continuing our deep dive into AML morphology, let's consider the cytoplasm, which offers another important differentiating clue when comparing myeloblasts to lymphoblasts. Myeloblasts typically exhibit more cytoplasm than lymphoblasts. While still considered immature, their cytoplasm is generally more abundant and less scant compared to the very narrow rim seen in lymphoblasts. This increased cytoplasmic volume can sometimes give myeloblasts a slightly larger overall appearance. Furthermore, the cytoplasm of myeloblasts may contain possible granules. These can range from fine, dust-like granules to more prominent azurophilic granules, depending on the subtype of AML and the stage of differentiation. The presence of these granules, even if subtle, is a key indicator of myeloid lineage, as lymphoblasts are typically agranular, while the basophilia or blue staining is still present due to high RNA content. The quantity and potential granulation of the cytoplasm are important features to assess. So, when evaluating blasts, pay close attention to the amount and characteristics of the cytoplasm, as these can help guide you towards an AML diagnosis. Now, let's shift our focus to the other major category of acute leukemia, all. Now, Let's shift our focus to the other major category of acute leukemia, acute lymphoblastic leukemia, or ALL. This is a malignant disorder characterized by the uncontrolled proliferation of immature lymphoid cells, known as lymphoblasts. This means a malignant transformation occurs in the lymphoid stem cells, or progenitor cells, which are normally destined to develop into B or T lymphocytes. A key demographic point is that ALL is more common in children, representing the most frequent childhood cancer, with a peak incidence between 2 and 5 years of age. However, it can also occur in adults, though less frequently. The clinical presentation often includes symptoms related to bone marrow failure, like fatigue, pallor, fever, and bleeding. Lymphadenopathy, hepatosplenomegaly, and bone pain are also common. Diagnosis requires identifying at least 20% lymphoblasts in the bone marrow or peripheral blood, along with specific morphological, immunophenotypic, and genetic features. Understanding that ALL stems from the lymphoid lineage is crucial for interpreting its characteristic cellular morphology and guiding diagnostic and therapeutic strategies. Next, we'll examine the specific morphology of these lymphoblasts. Moving from the overview of ALL, let's now delve into the specific morphology of lymphoblasts, the hallmark cells of acute lymphoblastic leukemia. Lymphoblasts are typically smaller than myeloblasts, though their size can vary. A defining feature of lymphoblasts is their scant cytoplasm. The nucleus occupies a very large proportion of the cell, resulting in a very high nuclear to cytoplasmic ratio, with only a narrow rim of basophilic or blue cytoplasm visible. This scant cytoplasm is generally a granular, meaning it lacks the specific granules that can be seen in myeloid cells. Crucially, lymphoblasts do not contain our rods. The absence of these needle-like inclusions is a key differentiating feature from myeloblasts. The nucleus of a lymphoblast typically has fine to slightly coarse chromatin, and nucleoli may be present but are often less prominent or indistinct compared to those in myeloblasts. While there can be some morphological variability among lymphoblasts, the overall picture, a high NC ratio, scant of granular cytoplasm, and absence of our rods is highly suggestive of ALL. So, meticulous attention to these morphological details is essential for accurate diagnosis. Next, we'll further explore the cytoplasmic characteristics of ALL. Continuing our discussion on ALL morphology, let's focus on the cytoplasm of lymphoblasts. Lymphoblasts typically exhibit significantly less cytoplasm compared to myeloblasts, which is a key differentiator. This scant cytoplasm contributes to the very high nuclear to cytoplasmic ratio that is characteristic of these immature cells. You'll often see it as just a narrow, basophilic rim surrounding the large nucleus. What's also important is the uniformity of the cytoplasmic appearance within the blast population. While there might be some variation in cell size or nuclear shape, the cytoplasmic features, its quantity, basophilia, and general lack of granules, tend to be quite consistent across all lymphoblasts. This uniformity, coupled with the scant nature of the cytoplasm, helps us distinguish lymphoblasts from myeloblasts, which often have more abundant cytoplasm and may contain granules. Remember, the absence of our rods further reinforces the lymphoid lineage. So, when you're evaluating blasts, pay close attention to the amount and consistency of the cytoplasm. These features are crucial for differentiating between ALL and AML. This leads us directly into a more direct comparison of AML and ALL. Now, let's bring it all together for an introductory level comparison of AML and ALL, focusing on the most straightforward morphological distinctions. For AML, think more cytoplasm, possible rods. Myeloblasts generally have a more abundant cytoplasm than lymphoblasts, and critically, they may contain our rods. The presence of these needle-like inclusions is almost pathognomonic for myeloid lineage and is a strong indicator of AML. Conversely, for ALL, remember less cytoplasm, no rods. Lymphoblasts characteristically have a very scant rim of cytoplasm around a large nucleus, resulting in that very high nuclear to cytoplasmic ratio we've discussed. And, importantly, lymphoblasts in ALL never contain our rods. While there are many other detailed differences, these two cytoplasmic features, the amount of cytoplasm and the presence or absence of our rods, provide a fundamental and often rapid way to differentiate between AML and ALL. This initial distinction is vital for guiding further diagnostic tests and initiating appropriate treatment protocols. But what does all this mean for the bone marrow itself? So, with this understanding of AML and all morphology, let's connect these observations back to the bone marrow, the primary site of the disease. In both AML and all, the bone marrow is experiencing a profound disruption. Firstly, there's uncontrolled proliferation of immature blast cells. These malignant precursors multiply rapidly and relentlessly without any normal regulatory checks. Secondly, there's a profound failure to mature. The blasts are arrested at an early stage of development and simply do not differentiate into functional mature blood cells. This means the marrow is producing a large quantity of non-functional cells. And as a direct consequence of these two issues, there's severe crowding of normal cells. The rapidly expanding population of blasts physically displaces and suppresses the healthy hematopoietic stem cells. This crowding leads to a significant reduction in normal hematopoiesis, resulting in peripheral blood cytopenias we often see. This dysfunctional environment, dominated by immature, non-functional cells, impairs the production of all other essential blood components. This directly explains why we see decreases in other cell lines, like red blood cells. Following from the bone marrow's dysfunction, one of the most consistent findings in acute leukemia is anemia, which presents as a decrease in red blood cells. The primary reason for this is quite simple. The marrow space is taken by blasts. The bone marrow is a factory for all blood cells, including red blood cells. In acute leukemia, the uncontrolled proliferation of leukemic blasts leads to their massive accumulation within the marrow. These blasts physically occupy the space that would normally be used by erythroid precursors, the cells that develop into red blood cells. This physical crowding and competition for resources effectively shuts down or severely impairs normal erythropoiesis. The healthy erythroid progenitor cells just can't proliferate and mature efficiently, leading to a reduced output of red blood cells into the peripheral circulation. Consequently, the patient develops anemia, contributing to symptoms like fatigue and shortness of breath. This direct impact on red blood cell production is a clear example of how the uncontrolled growth of blasts disrupts the entire hematopoietic system. And it's not just red blood cells that are affected. Just as with red blood cells, another common and clinically significant finding in acute leukemia is thrombocytopenia, a decrease in the number of platelets. The primary reason for this reduction is the suppression of megakaryocytes within the bone marrow. Megakaryocytes are those large bone marrow cells responsible for producing platelets, which are crucial for blood clotting. In acute leukemia, the rampant proliferation of leukemic blasts overwhelms the bone marrow environment. These blasts physically displace and inhibit the normal development and function of megakaryocytes. The healthy megakaryocytic progenitor cells are unable to mature and produce platelets effectively, leading to a significant reduction in platelet output into the peripheral circulation. This suppression results in thrombocytopenia, which increases the patient's risk of bleeding and bruising. So, the decrease in platelets is a direct consequence of the leukemic process disrupting normal megakaryopoiesis, highlighting another systemic impact of acute leukemia on the hematopoietic system. It's truly a system-wide failure. We've just discussed how megakaryocytes are suppressed, leading to decreased platelets. Now, let's zoom out and consider the broader implications of acute leukemia. It's crucial to understand that acute leukemia isn't just a problem of white blood cells. It represents a profound, system-wide hematopoietic failure. The uncontrolled proliferation of blasts in the bone marrow doesn't just affect one cell line. It impacts the entire blood-forming process. This relentless expansion of immature cells crowds out the healthy stem cells, leading to a severe reduction in red blood cells, mature white blood cells, and platelets. Consequently, patients experience anemia, increased susceptibility to infections, and a heightened risk of bleeding. This systemic disruption cripples the bone marrow's ability to produce all essential blood components. So, when you see blasts, remember you're looking at a breakdown of the entire hematopoietic system, not just an isolated issue. This holistic view is vital for appreciating the clinical urgency and the need for comprehensive intervention. Next, we'll explore specialized diagnostic tools that help us further characterize these failures. Building on our understanding of system-wide hematopoietic failure, we now turn to specialized diagnostics, cytochemical stains. These stains are indispensable tools in hematology, offering crucial insights into the lineage and maturation stage of abnormal cells, especially blasts. While routine right Giemsa staining provides a wealth of morphological information, cytochemical stains leverage specific enzymatic activities or chemical compositions within cells. They allow us to detect substances like enzymes, lipids, or glycogen that are characteristic of certain cell types. This additional layer of information is often critical for differentiating between AML and all, and even for subtyping within these broad categories. These stains provide objective, biochemical evidence that complements our morphological observations. They help us move beyond subjective interpretations and provide a more definitive classification of leukemic cells. We'll start by examining the myeloperoxidase stain, a key marker for myeloid and monocytic differentiation. Following our introduction to specialized diagnostics, let's delve into one of the most important cytochemical stains, myeloperoxidase, or MPO. This stain is a powerful tool for identifying cells of granulocytic and monocytic lineage. MPO is an enzyme found in the primary granules of myeloid cells, and its presence indicates differentiation along the myeloid pathway. When performing an MPO stain, a positive reaction appears as dark brown or black granules within the cytoplasm of the cells. A strong positive reaction is characteristic of myeloblasts and promyelocytes, while monocytes show a weaker, more diffuse positivity. Crucially, lymphoid cells, including lymphoblasts, are consistently MPO negative. This clear distinction makes MPO an invaluable stain for differentiating AML from all. A positive MPO reaction in blasts strongly supports a diagnosis of AML, guiding further subclassification. Understanding the significance of MPO positivity is fundamental for accurate acute leukemia diagnosis. After discussing the MPO stain, we move to another critical cytochemical stain, Sudan black B or SBB. SBB is a lipid stain that detects phospholipids and other lipid components present in the granules of myeloid cells. Its staining pattern closely parallels that of MPO, making it another excellent marker for granulocytic and monocytic differentiation. SBB stains the lipid content within primary and secondary granules, appearing as black or dark brown granules in the cytoplasm. Myeloblasts and granulocytes typically show strong SBB positivity, with the intensity increasing with maturation. Monocytes also exhibit SBB positivity, often with finer, more diffuse granules. Similar to MPO, lymphoid cells, including lymphoblasts, are consistently SBB negative. This makes SBB an equally valuable stain for distinguishing AML from all, especially in cases where MPO results might be equivocal. The presence of SBB positivity in blasts provides strong evidence for a myeloid lineage. Next, we'll explore nonspecific esterase, a stain with a different specificity. Having covered MPO and SBB, which are excellent for myeloid lineage, let's now examine nonspecific esterase, or NSE. This stain is particularly useful as a monocytic marker, helping us identify cells differentiating along the monocytic pathway. NSE detects esterase enzymes found in monocytes and macrophages. There are two main types of NSE, alpha-naphthyl acetate esterase and alpha-naphthyl butyrate esterase, both of which are inhibited by sodium fluoride. A positive NSE reaction typically appears as a reddish-brown precipitate in the cytoplasm. Monoblasts and monocytes show strong, diffuse positivity, which is often inhibited by sodium fluoride. Granulocytic cells, including myeloblasts, are generally negative or show only weak, focal positivity. Lymphoid cells are also negative. This distinct staining pattern makes NSE crucial for identifying monocytic components in acute leukemias, particularly in subtypes of AML with monocytic differentiation. Understanding NSE helps us further refine our classification of acute leukemias. Next, we'll discuss the periodic acid shift stain. Moving beyond esterase stains, the periodic acid shift, or PAS, stain is another crucial cytochemical tool in our diagnostic arsenal, particularly for assessing glycogen content. This stain is incredibly useful for differentiating between certain types of acute leukemias, especially when morphology alone isn't definitive. We're looking for a characteristic staining pattern that indicates the presence of glycogen. For instance, in acute lymphoblastic leukemia, or all, you'll often see a block-like or granular pattern of PAS positivity in the lymphoblasts. This contrasts with myeloblasts and AML, which typically show a diffuse, weak, or negative reaction. Understanding these nuances helps us pinpoint the lineage of the blasts. It's not just about seeing color. It's about interpreting the pattern and intensity of that color. This cytochemical reaction provides a biochemical fingerprint, guiding us toward an accurate diagnosis. So, while we've covered the myeloid markers, remember that PAS helps us identify lymphoid characteristics. This takes us closer to understanding the specific type of leukemia. Building on our discussion of cytochemical stains, terminal deoxynucleotide transferase, or TDT, is a powerful nuclear enzyme marker that's indispensable for identifying immature lymphoid cells. TDT is a DNA polymerase found in the nuclei of pre-B and pre-T lymphocytes, making a highly specific marker for immature lymphoid cells or lymphoblasts. Its presence is a strong indicator of acute lymphoblastic leukemia, or all, and is rarely seen in myeloblasts. When you see strong nuclear positivity for TDT, it immediately points you towards a lymphoid lineage. This marker is particularly helpful in cases where morphological features are ambiguous or overlap between AML and all. So, while PAS gives us a clue about glycogen, TDT provides definitive evidence of lymphoid immaturity. This specific enzymatic activity helps us confirm the lymphoid nature of the blasts. This brings us to a more comprehensive approach to cell identification, moving beyond single markers. Now, let's talk about immunophenotyping, which truly represents the power of flow cytometry in modern hematology diagnostics. This technique allows us to identify specific cell surface and intracellular antigens, providing a highly detailed fingerprint of a cell's lineage and maturation stage. We use a panel of fluorescently labeled antibodies that bind to these specific markers. Flow cytometry then rapidly analyzes thousands of cells, creating a comprehensive profile. This is crucial for definitively classifying acute leukemias as either myeloid or lymphoid, and even subtyping them further. For example, we can identify specific CD markers that are characteristic of B-all or T-all, or various AML subtypes. Immunophenotyping provides objective, quantitative data that complements our morphological and cytochemical findings. It's a critical step in confirming the diagnosis and guiding treatment decisions. This detailed cellular characterization is essential for precise patient management. Beyond morphology and immunophenotyping, genetic and molecular findings have revolutionized our understanding and classification of acute leukemias. These advanced techniques allow us to detect specific chromosomal abnormalities, gene mutations, and fusion genes that are characteristic of different leukemia subtypes. For instance, the Philadelphia chromosome, or BCR, ABL1 fusion gene, is a classic example in all, while various translocations are seen in AML. These genetic alterations are not just diagnostic markers. They often have significant prognostic implications and can guide targeted therapies. They provide insights into the underlying biology of the disease, helping us predict how a patient might respond to treatment. So, while morphology gives us the initial visual clues and immunophenotyping confirms lineage, genetic studies offer the deepest level of characterization. This comprehensive approach ensures the most accurate diagnosis and personalized treatment strategy. This detailed understanding of the disease helps us anticipate the clinical picture. Now, let's connect these laboratory findings to the real-world clinical presentation of acute myeloid leukemia, or AML. Patients often present with a constellation of symptoms directly related to bone marrow failure. You'll typically see a variable white blood cell count. It can be very high, very low, or even within the normal range. However, regardless of the total count, the presence of circulating blasts is the critical finding. Anemia is almost universally present, leading to fatigue and pallor, because the blasts crowd out normal red blood cell production. Thrombocytopenia, a low platelet count, is also common, increasing the risk of bleeding and bruising. These symptoms often develop rapidly, reflecting the aggressive nature of AML. So, when you see a patient with unexplained fatigue, easy bruising, and perhaps recurrent infections, always consider the possibility of AML. This clinical picture is a direct consequence of the marrow being overrun by immature myeloid cells. Understanding these clinical signs helps us appreciate the urgency of accurate diagnosis. While AML often presents with symptoms directly related to bone marrow failure, all has a slightly different clinical picture that's important to recognize. Here, we're looking at common clinical presentations of acute lymphoblastic leukemia, which often extend beyond just the blood counts. Lymphadenopathy, or swollen lymph nodes, is a frequent finding because all involves the lymphoid lineage, and lymph nodes are central to the lymphatic system. Hepatosplenomegaly, an enlarged liver and spleen, also occurs commonly as these organs become sites of extramedullary hematopoiesis, or infiltration by leukemic cells. The bone pain, often severe, is due to the rapid proliferation of lymphoblasts within the bone marrow, causing pressure and expansion. These symptoms, especially in a pediatric patient, should immediately raise suspicion for all. Your role in confirming the presence of lymphoblasts in the peripheral blood or bone marrow is crucial in connecting these clinical signs to a definitive diagnosis. Understanding these broader clinical manifestations helps you appreciate the systemic impact of all. These clinical clues, combined with your morphological findings, paint a comprehensive picture. Now, let's consider what factors influence the outcome for patients with acute leukemias. Understanding the clinical presentation is vital, but what truly matters for the patient is their prognosis. The outcome in acute leukemias is not uniform. It's influenced by a complex interplay of factors. Patient age is a significant prognostic indicator, with pediatric ALL generally having a better prognosis than adult ALL or AML. The specific subtype of leukemia, determined by morphology, immunophenotyping, and cytogenetics, also plays a critical role. For instance, certain genetic translocations are associated with more favorable or unfavorable outcomes. Initial white blood cell count at diagnosis can also be prognostic, with very high counts sometimes indicating a more aggressive disease. The response to initial therapy is perhaps one of the most immediate and impactful prognostic factors. Your accurate identification of blasts and contribution to subtyping is foundational to assessing these factors. These elements collectively guide treatment decisions and help predict a patient's journey. Next, we'll dive into a case study to see how these concepts apply in a real-world pediatric ALL scenario. Building on our discussion of prognostic factors, let's examine a typical case of pediatric ALL to solidify our understanding. Imagine a young child presenting with fatigue, pallor, and unexplained bruising, classic signs of bone marrow failure. They might also have lymphadenopathy and bone pain, as we just discussed. A peripheral blood smear would likely reveal anemia, thrombocytopenia, and critically, a significant percentage of lymphoblasts. These lymphoblasts would exhibit the characteristic high NC ratio, scant cytoplasm, fine chromatin, and prominent nucleoli we've reviewed. The absence of Auer rods would further support the lymphoid lineage. Diagnostic confirmation would then involve a bone marrow aspirate and biopsy, showing hypercellularity with greater than 20% lymphoblasts. Immunophenotyping would confirm the B cell or T cell lineage, and cytogenetic studies would identify specific genetic abnormalities. This comprehensive approach, where your morphological assessment is the first critical step, leads to an accurate diagnosis. This case highlights the urgency and precision required in pediatric leukemia diagnosis. Now, let's contrast this with an adult AML case. Having explored a pediatric ALL case, let's now turn our attention to an adult AML presentation, noting the key differences. An adult patient might present with similar symptoms of bone marrow failure, fatigue, recurrent infections, and bleeding, but often without the prominent lymphadenopathy or bone pain seen in ALL. A peripheral blood smear would again show anemia, thrombocytopenia, and the presence of blasts. However, in this case, the blasts would be myeloblasts characterized by slightly more cytoplasm, and crucially, the potential presence of Auer rods. These needle-like inclusions are the definitive morphological marker for AML. Diagnostic confirmation would follow a similar path, a bone marrow aspirate and biopsy, revealing hypercellularity with greater than 20% myeloblasts. Immunophenotyping would confirm the myeloid lineage, and cytogenetic analysis would identify specific AML-associated genetic aberrations. This case underscores how your meticulous morphological analysis, particularly the search for hour rods, is paramount in differentiating AML from all. These case studies demonstrate the practical application of all the morphological nuances we've covered. Finally, let's reflect on your indispensable role in this entire process. We've covered a tremendous amount of ground this week, from blast recognition to the intricacies of acute leukemias and their clinical presentations. It's time to conclude by emphasizing the histotechnologist's vital role in this entire diagnostic pathway. Your keen eye and meticulous attention to detail are the first line of defense against these aggressive diseases. The accurate identification of blasts, the differentiation between AML and all, and the recognition of marrow dysfunction all hinge on your expertise. You are not just looking at cells. You are interpreting the earliest signs of life-threatening conditions. Your precise and timely reports directly influence patient management, guiding clinicians toward appropriate and often life-saving treatments. Without your foundational work, the complex diagnostic algorithms and therapeutic strategies for acute leukemias simply wouldn't be possible. Embrace this responsibility. Continue to hone your skills, and remember the profound impact you have on patient lives. Your contribution is truly indispensable.